Okay, now for a final talk before the refreshment break, Jeanine Kamphuis is going to tell us about oral esketamine as an alternative for ECT. So that's quite topical.
Yes, so for me as well, many thanks to the organization for the opportunity to present here. And I will elaborate on another clinical use that we've been trying, this oral esketamine treatment that Jeanine, my colleague, just told about. I'm also a psychiatrist working in the University Hospital in Groningen on a clinical ward for mood disorders. And there we treat patients with very severe depression with ECT, but also with ketamine. And in the coming 10 minutes, I will share a small case series that we've been doing for using oral esketamine as a substitute for maintenance ECT. I have no conflicts of interest to declare. And as you probably know, ECT has very high response rates. They vary from 45 to 60%, depending on whether or not a patient had psychotic features. Then the response rates will be a little bit higher, up to 60%. But relapse rates are also very high. Without additional treatment, 85% of patients will relapse within the first 6 months after successful ECT. And we can reduce these relapse rates with additional treatment, with pharmacotherapy, and maybe phase out the ECT. But then relapse rates are still 30 to 50%. So you also need to do something after the ECT. But for those patients who keep on relapsing after ECT, maintenance ECT is a strategy that you can use to reduce the relapse rate. And in a meta-analysis by Elias and colleagues in 2018, it was shown that maintenance ECT can reduce relapse rates then to approximately 19%, which of course is then very good. And maintenance ECT will then entail that you reduce the ECT frequency to maybe once a week to once every 2, 3, 4 weeks. And you can imagine that this still has several drawbacks, of course. So you still need your repeated general anesthesia. You need your clinical team in the psychiatric facility with your anesthesiologist. So this is also quite costly. But I think most importantly for these patients, it's a choice between two harms. So they need their stability, but they're also dependent on this ECT, and this will still give cognitive deficits and also have quite an impact on their daily lives. So if there is a strategy that can be a substitute for this maintenance ECT, this is worthwhile trying. And we've had some patients that we tried this with our oral esketamine program. So in the last years, we've tried this in 8 patients. And here you see some characteristics of these patients. We had, most of them were female, 6 females, 2 males. And most of them also had a unipolar, so major depressive disorder. And 2 of them had a bipolar disorder, bipolar 2 disorder. Several ages, and also they stated that they had self-reported depressive episodes varied quite a lot, but there were also patients who just had a very persistent depressive episode from which they could not recover quite well. Also several psychiatric comorbidities. And if we look, when we started the oral esketamine treatment, these patients had on average already quite some months of maintenance ECT. On average, this was 22 months. And in these 22 months, they also got quite high numbers of ECT sessions, of course, on average 58. So these patients were dependent on this maintenance ECT for stability. And we tried this oral esketamine trial, we tailored it individually. So in 3 of them, we stopped the maintenance ECT and then tried the oral esketamine. But in the remaining 5, we added the oral esketamine in a regimen of 2 times a week for the duration of 6 weeks. And then we tried to phase out, taper down the ECT frequency. And we did this in shared decision-making with the patients. And here you see I'm not sure if I can see the point, but you can see it. the IDS score, so the depression severity on the y-axis, pre and post esketamine. And you also see from the height of these lines, so one line represents one patient, right? That some of these patients were still quite severely depressed. But they were able to, with the maintenance ECT, to reach some stability. And of course, our goal was to taper down the maintenance ECT. So our goal was to keep them stable. But you can see that in some patients, it was also able to decrease the depression severity. In one patient, the depression severity, you see the brown line, it actually increased, and there we also decided to stop, of course, and go back to maintenance ECT. So from these 8 patients, of course, it's a very small number, but 6 patients were able to stop ECT completely, and they continued for a period with this oral esketamine. 2 patients continuously required also the ECT, 1 in a lower frequency. And we have still 4 of these 8 patients using esketamine. And also, as Jeanine explained, they then use this at home through our program. And on average, they've been doing this already for 2 years now. So it's also quite a long experience that we have now. We followed them, of course. 3 of these patients at some point stopped with oral esketamine after several months of use because of insufficient effect on the depression. And they got back on maintenance ECT. And we had 1 patient, he stopped after an anxious experience at home. After 27 months of use, he got in a dissociative state, which was very uncomfortable for him, but he also experienced this before. So it's a bit for us unclear how this exactly happened, but he didn't want to start again, but was stable enough also to remain stopped with the oral esketamine and also did not go back to the ECT. So for us, if we have somebody now on maintenance ECT, we will also consider oral esketamine. That's what we learned from this. So esketamine can be an alternative for maintenance ECT. And for some, it seems that side effects are more tolerable. Quality of life is better, but also for some, it seems that they still are dependent on this highly effective treatment that we also have with ECT, of course. And I'm wondering if in 5 years we will still have these patients that we start with ketamine after they already started ECT, because it seems that we're going to a development that we will start ketamine prior to the ECT. We also heard yesterday of several studies that are ongoing there. And we also have now in the Netherlands the intranasal esketamine spray that we can already start actually quite early in the protocol. And we have also been doing this in our hospital. So I wonder how that will go. We are also conducting a randomized controlled trial ourselves with 7 sites in the Netherlands, where we compare oral esketamine as described, as we just described, with ECT. And there we also offer this maintenance phase, and we follow responders for 1 year. So perhaps in 2 years we can present those results. We have quite a large research group. I'm also in the group of Robert Schoeffers, but these are the persons that also participated in preparing these results in a short manuscript that we've submitted. And Daan Koerts is the student that did all this work in writing this up. So thank you for your attention.
Fantastic. Another great demonstration of what treatment for depressed patients really looks like. Kind of complex, dynamic, and you have to do whatever you have to do. Really lovely. Does anyone have any questions before we go for coffee?
Did you get any tolerance?
That's a really good question, because we are starting to see this. So we have this oral esketamine program, not only for these 8 patients, but we've been treating a lot of patients, and we do start to see that now with patients who have been using this for several years, tolerance, but also then tolerance for the antidepressant effect. So they start to see the effect on the depression diminishes. And the strange thing is, I'm also not sure how this is with other administration routes, But we have patients that have been using this for years and they have the same intensity of dissociation as they had in the first weeks. But we have also patients that they say, it's like I drink a tap of water. It's very, a lot of variety. Yeah.
Thanks again. Coffee break, back at 15:15.